I post videos like this every week. If that's your thing, hit like, subscribe, and stick around. Now, back to the video. A 14-year-old male identified as TJ presented to the emergency room exhibiting muscle weakness, abdominal pain, and an upper extremity fracture. Initially triaged as a low-priority case, the patient subsequently experienced a decline in consciousness, progressing to a comatose state. Prior to his presentation, TJ and his mother had relocated to the United States following a period of family distress. The family, while not economically disadvantaged, faced a language barrier and cultural unfamiliarity in their new environment. TJ had a long-standing preference for gummy candies. Upon arrival in the United States, his mother purchased multiple bottles of gummy products for him. Due to a misunderstanding regarding product labeling and cultural norms, the family perceived these bottled gummies as conventional candy. Consequently, TJ routinely consumed 30 to 40 pieces daily, unaware that these items were in fact vitamin supplements. Over time, TJ's mother observed progressive abdominal distension in her son, initially attributing this symptom to dietary changes associated with their new environment.
On the morning of admission, TJ consumed an entire bottle, approximately 150 pieces of the gummy supplements. Approximately 1 hour post-ingestion, TJ developed polyuria and reported severe, constricting epigastric pain that subsequently radiated to the throat. While his mother attempted to assist him, TJ sustained a fall, resulting in the aforementioned arm fracture. Emergency medical services were then contacted. During transport to the emergency department, TJ experienced nausea and signs of shock related to the incident. Upon arrival, the patient's condition was initially assessed as a simple fracture. However, his subsequent progression to a coma necessitated immediate medical re-evaluation. The skeletal fracture was identified as a manifestation of an underlying systemic pathology, with the patient's history providing several diagnostic indicators. Physical examination revealed dry skin and fractured nails on the lower extremities, alongside prominent ascites. Although initial assessment suggested hepatic involvement due to ascites, blood tests indicated normal liver function but revealed severe hypercalcemia. Hypercalcemia, defined as an abnormally high concentration of calcium in the blood, was thus confirmed. Analysis of the ingested gummy vitamin product indicated no calcium content. The patient's mother reported no emesis or defecation since the acute ingestion of 150 gummies, suggesting minimal elimination of ingested substances from the gastrointestinal tract. Consequently, significant systemic absorption and detectable circulating levels of the vitamins were anticipated. However, subsequent blood analyses revealed no significant elevations in vitamins A through E, iodine, zinc, or selenium. The patient exhibited dehydration, consistent with the reported polyuria preceding his comatose state, which provided an initial diagnostic clue. The absence of detectable vitamin levels in the bloodstream, despite massive ingestion, suggested rapid renal excretion. Water-soluble vitamins, B and C, are known to be readily dissolved in water, concentrated in the kidneys, and excreted via urine, which aligns with the observed polyuria. However, this explanation is incongruent with fat-soluble vitamins, A and E, which are not water-miscible and therefore not typically eliminated renally. Given their absence in blood, non-renal elimination, and lack of gastrointestinal expulsion, the logical inference was that excess fat-soluble vitamins A and D were sequestered within internal organs. Muscular and cardiac tissues were deemed unlikely reservoirs due to their aqueous composition. While neural tissue has a high lipid content, the absence of circulating vitamin levels rendered cerebral sequestration improbable.
Considering the oral route of administration, the vitamins would have been absorbed from the gastrointestinal tract and first metabolized by the liver. The earlier observation of ascites provided a physical indication of potential hepatic compromise. This constellation of findings strongly suggested hypervitaminosis as the etiology for the observed hepatic damage, hypercalcemia, and skeletal fractures. A transjugular liver biopsy performed via catheterization from the jugular vein revealed an increased proliferation of fat-laden hepatic stellate cells. This indicated chronic vitamin A accumulation within the liver parenchyma, leading to cellular engorgement, necrosis, and fibrosis. These findings confirmed vitamin A-induced hepatotoxicity, a cumulative effect of daily ingestion of 30 to 40 gummy vitamins since arriving in the United States. The acute ingestion of 150 gummies on the day of presentation resulted in an estimated intake of 187,000 international units of vitamin A. This acute dose was approximately 63 times the recommended daily allowance, while his typical daily intake of 30 to 40 pieces constituted approximately 20 times the RDA. These excessive intakes directly contributed to the diagnosis of hypervitaminosis A and the observed liver damage.
Retinol, vitamin A, is known to antagonize vitamin D action, potentially impairing its physiological effects in cases of excess. Reconsidering the patient's hypercalcemia is crucial at this juncture. Vitamin D primarily functions by enhancing intestinal absorption of dietary calcium. Despite no exogenous calcium intake from the gummies, TJ's acute consumption included 75,000 units of vitamin D, representing 188 times the recommended daily value. Given the inhibitory effect of hypervitaminosis A on vitamin D-mediated intestinal calcium absorption, the persistent hypercalcemia suggested an endogenous source. The primary endogenous reservoir of calcium is skeletal bone. Vitamin A is metabolized into active retinoic acid, a compound known to stimulate osteoclast formation. Osteoclasts are specialized cells responsible for bone resorption, which involves the breakdown of bone matrix and the release of calcium into the bloodstream. Chronic bone resorption, exacerbated by TJ's prolonged unintentional consumption of vitamin A,
The phenomenon of nutrient overconsumption leading to iatrogenic injury is a recognized concern in contemporary medicine. Historically, vitamin D fortification of milk, implemented to combat rickets, bone softening, and deformation in children, led to unintended consequences. In 1956, the British Pediatric Association documented 204 cases of hypocalcemia in infants, resulting from vitamin D intoxication due to non-standardized fortification, which often resulted in failure to thrive and potential growth impairment. Epidemiological studies have indicated significantly higher average vitamin A intake in Scandinavia, e.g. Sweden and Norway, compared to Southern Europe, up to 6-fold. Individuals with daily vitamin A consumption exceeding 5,000 IU exhibited a 10% reduction in bone mineral density and more than doubled their risk of hip fracture relative to those consuming less than 5,000 IU per day.
A historical account from 1597 describes a Dutch expedition to Nova Zembla, present-day Canada, where crew members consumed polar bear liver, subsequently developing severe illness characterized by dermatological desquamation. In 1942, vitamin A was identified as the toxic agent in the livers of carnivorous animals like seals and polar bears, with 100 grams containing 1.3 to 1.8 million IU of retinol, significantly higher than the approximately 50,000 IU found in herbivore livers. Paleoanthropological evidence includes a Homo erectus skeleton from Kenya, dated approximately 1.5 million years ago, exhibiting enlarged osteocytes with lacunae, indicative of osteolysis and partial dissolution of the bone matrix. This skeletal weakening is characteristic of vitamin A intoxication, and the age of the specimen aligns with hypothesized increases in early human meat consumption.
This suggests that the pathophysiological mechanisms of liver damage, ascites, hypercalcemia, and skeletal deterioration observed in this proto-human were analogous to those in the present case.
Medical interventions for TJ included orthopedic management of the fractures, behavioral counseling to mitigate future injury risk, and diuretic therapy including spironolactone and furosemide for ascites. These diuretics promote natriuresis by increasing renal sodium resorption, thereby facilitating water excretion. However, direct pharmacological removal of hepatic vitamin A stores is not feasible. Consequently, the patient was expected to endure the manifestations of acute and chronic hypervitaminosis A until hepatic clearance of retinal esters could be achieved. Due to the patient's transient status in the United States, long-term follow-up data are unavailable. At the time of discharge, observed improvements included resolution of nail and skin dystrophy and diminished ascites, suggesting initial recovery from hepatic insult. The patient's understanding of the supplement's true nature led to immediate cessation of vitamin intake. A scheduled follow-up appointment was not attended. Although the ultimate prognosis for TJ remains unknown, his condition demonstrated signs of recovery at the last clinical encounter.